Mavery, and this is our Fegnomashic review. So, Fegnomashic has a mixture of both some of our primary or our metastatic stuff, as well as our malignant stuff, as well as our benign stuff. And Fegnomashic is defined or is used as the DDX when we see a geographic lytic lesion, which we're going to see a lot of them. And there's a couple of ways of organizing this. So I'm going to first just define each of these, and then I'm going to show you how I always wrote out my Fegnomashic. So I didn't write it out like this. I wrote it out a little differently. And you can choose whether to just remember a Fegnomashic like this or to do it how I did it. So Fegnomashic stands for, so I'll give each of them a color. So the F stands for our fibrous dysplasia. The E is going to stand for our enchondroma. The G stands for giant cell tumor. The N is kind of like a placeholder in a way, is standing for our non-ossifying fibroma. Our fibrous cortical defect. And what we call it in 20 plus, which would be our fibrous xanthoma. The O in Fegnomashic stands for our osteoblastoma. I'll write it all the way out. Our M is going to stand for two things. So the M stands for our plasmacytoma. Remember that a plasmacytoma is a solitary form of multiple myeloma. And then also our blowout Mets. The A stands for aneurysmal bone cyst. The S stands for our simple bone cyst. You will learn what the H and the I stand for the third exam. So right now we don't have to worry about these. And the C, I'm not going to take it all the way away because I think it looks, so I'm just going to black them out. Don't have to worry about these right now. And the C is going to be our chondroblastoma. Remember that the other name for chondroblastoma is our Codman tumor. Okay, so that is our list. That is what each of these stands for. And remember that with these, we always wanted to think about what are the age ranges for each of these, and is it painful, non-painful. So that's how I like to divide it, is I divide it based on painful and non-painful. So you can write Fegnomashic, but what I always think of whenever I see a geographic lytic is I write down my lists. So I have my painful list and my non-painful list. And that's just how I always broke it down. And from that, my painful list includes fibrous dysplasia, giant cell tumor, osteoblastoma, both plasmacytoma and my blowout mets, my ABC, and my chondroblastoma. So this is for plasmacytoma and blowout mets, ABC, CB. For my non-painful, I have FENS. So fibrous dysplasia can be painful or non-painful. E stands for enchondroma. N stands for my NOF, FCD, or FX. Don't ever abbreviate it FX though. Always write out for this one, fibrous xanthoma, because FX is fracture. And then SBC. Okay, so that's the first thing I do. So I separate it like that. I'm going to just give them a little more space. So then the first question I always ask myself when I come to an image is I go, in the history, was I told is this painful or non-painful? And if I'm told, then I kind of separate and I go, do I go to my FENS list or do I go to my, you can say FGOMAC or FGOMAC. Most people, I just said GOMAC and then I just remember fibrous dysplasia is both of them. But that's kind of where you start. Now let's talk about age stuff. So let's go through the ages for each of these. So with fibrous dysplasia, you usually get them between 8 and 14, but you keep it forever. Our GCT, 20 to 40. Our OB, 10 to 20. Plasmacytoma, 40 plus. Blowout Mets, 50 plus. ABC, 5 to 20. Chondroblastoma or Codman's tumor, 10 to 25. Fibrous dysplasia, we already said, right? 8 to 14, we keep it forever. Enchondroma, 10 to 30, and we keep it forever. NOF, FCD, and fibrous xanthoma, those ones depend on the age. So NOF is going to be our 8 to 20. FCD is our 4 to 8. And fibrous xanthoma is our 20 plus. And then simple bone cysts, or SBC, that is, we can develop it from 3 to 14, and we keep it forever. So what are we kind of noticing is that our forevers are our non-painful. So a non-painful thing, really, age doesn't matter. If you think about it, right? Because basically I've covered all the age groups with my non-painful, right? Fibrous dysplasia from 8 to forever. Enchondroma, 10 forever. Our NOF, FCD, and fibrous xanthoma cover the age range from 4 to forever. And then simple bone cysts, 3 forever. So things that go on, age doesn't matter as much as non-painful. Where does age matter more? Painful stuff. Okay, so we're using age kind of as our benefit. And then from there, remember we have buzzwords for each of these. And so I want you to think of all of those different buzzwords that we related to them. And as we go through differentiating, I'll kind of remind you some of those buzzwords. And we'll kind of come back at the end and look at this list and put on what are our main buzzwords for them. So let's look at some images and use our Fegnomashic. So for the first image, here we are in the calcaneus and we see this geographic lytic lesion in the calcaneus. Now, if this had a little target sequestrum in the middle, we would immediately say, oh, this is in Fegnomashic, this is an interosseous lipoma. But the interosseous lipoma is not there. So now I have to kind of use my brain and be like, okay, gosh, what am I going to do? So we're going to DDX this. So geographic lytic lesion, and we're going to say that for this individual, it is non-painful. Non-painful in the foot, and that's all I know. I don't even know their age. I just know it's non-painful in the foot. So what am I going to put? That rhymed. So I'm going non-painful, so I'm going to put FENS, right? So FD and chondroma. I don't know the age, so NOF, FCD, and FX. And then simple bone cyst. So now looking at these, I would be like, I don't know how to tell the difference. Well, it's not NOF, FCD, or FX because it's not in a tubular bone on the side, right? Eccentric, remember? So these ones, let's kind of just define some things with these ones. Let me give myself a little more room. Okay, so let's kind of define each of these. So let's rule out NOF, FCD, and fibrosanthoma. So we know age-wise, so kind of what are the things that we know about these? So age-wise, our NOF is going to be our 8 to 20. FCD is our 4 to 8. And our fibrosanthoma is our 20 plus. Okay, so age-wise, we know that. These ones like to be eccentric on the side. Right, okay, and so this one we're like, okay, well, I don't necessarily see that in this situation, so I can be like, not really going towards that here. The next thing that I'm looking at is, okay, so it's not eccentric. We don't really have thickening or kind of that, I don't want to say thickening, but the sclerotic border. I don't really see a really sclerotic border around it. And we're not really in a tubular bone, which is where we're really going to see that for the most part, is where we're going to see the NOF kind of flourishing in that idea. Okay, so I'm not really seeing that. So that's kind of ruling out. So it's not eccentric, so we don't have a sclerotic border. We don't really have the thickening on the cortex. So I'm not really going NOF. So we're going to cross that out. Let's reduce something else. So let's talk about fibrous dysplasia. Now remember, fibrous dysplasia could always be an option. But with fibrous dysplasia, the main idea is that long lesion to long bone. And what I'm looking for when I am looking at an osteolytic fibrous dysplasia, so one that doesn't have, right, I don't see a fibrous, there's no fibrous cortex in here. I'm seeing, is there a rind of sclerosis? Well, not really. Doesn't look like there's something bright. And again, we would see that in both of these. We'd see that kind of rind of sclerosis-like appearance. Remember, FD, just to put this here, is 8 to 14, and we keep it forever. Some other things that we see with FD is we can see something like shepherd's crook. Well, we're in the foot, so that's not happening. But that's something with FD that we could see. And the other thing is something like an otopelvis, where we have the sclerosis or the thickening that is going into the pelvis. So we're kind of pushing the femoral head into the pelvis. With FD, remember that we have 3 types. So we have monostotic, polyostotic, and then the one that's specific to females, which is McCune-Albright. That's female only. That's where they have the endocrine things. And then the last kind of buzzword or something that you want to do with FD is look at if they say that there's any dermatological findings, such as a café au lait. Café au lait. And the one with FD is going to be the coast of Maine. Remember, it's jagged. So really, looking at this, well, it's not a long lesion. It's not a long bone. There's no rind of sclerosis. I don't really see any fibrous matrix. So FD really isn't on my list. At the end of the day, could it be FD? Yes, but it's not on my list. It's not high likelihood. So that leaves me enchondroma and simple bone cyst. And one thing I didn't tell you is that enchondromas and simple bone cysts really like, well, enchondroma, right? Most common benign tumor of the hands and feet. Well, we're looking at calcaneus, that's in our feet, so that one's definitely on my list. So enchondroma is definitely on the list. Simple bone cysts also really like the feet. They really like the calcaneus as well. So commonly the three things when I see something on the feet that I'm looking at, I'm going to put enchondroma, simple bone cyst, and interosseous lipoma. We don't see that the little target in there, right? That little calcification. So I'm putting interosseous lipoma at the bottom of my list. So really my DDX here is going to be enchondroma because it's the most common. So that's going to go first. Simple bone cyst, and then an interosseous lipoma that has not calcified yet. But it would be last on my list. So that's how I do my list. Let's just talk about the buzzwords or kind of define enchondroma and simple bone cyst a little bit more, even though we kind of already DDX'd them. So, talking about enchondromas, what are the main ideas? I can't spell. Enchondroma. So the first thing that we're looking at with our enchondromas is that this is the most common in hands and feet. That's an important idea. So it is the most common benign tumor in our hands and our feet. It is painless, 10 to 30, but we keep it forever. So that's an important thing. It has less than 1% chance of malignant transformation. If it does go through malignant transformation, remember that it goes to a chondrosarc. But less than 1%, not a big deal. If I have multiple enchondromas, we call it Ollier's disease. Ollier's disease has an increase of malignant transformation. We have 25% chance of malignant transformation. And then if I have Ollier's plus Maffucci's, or plus Maffucci's, sorry, plus phlebolyths, we have Maffucci's. Remember that phlebolyths are soft tissue hemangiomas. So we have Maffucci's. So that's kind of the kind of like main ideas when we're looking at enchondroma. So most common in the hands and feet, it's going to be a geographic lytic lesion. Now with our enchondromas, we can also see it in relation to our ice lesions. Ice baby. So it can also, if it is seen in a long bone, it could give us an ice lesion. But of course, the ice lesion, we wouldn't Fegnomashic it, right? An ice lesion is not a Fegnomashic thing because it's no longer a geographic lytic lesion. But enchondromas can appear as either a geographic lytic lesion or an ice lesion. Now, just to sidetrack and talk about ice lesion for a second, what does ice lesion stand for? Infarct. Sorry, I skipped the C. Infarct, chondrosarc, and enchondroma. The only non-painful out of any of them is this one. This one's the painless one. The rest would be painful. So that's kind of how I could also use that DDX. So that's that ice lesion DDX. And then our last one to just kind of what are our buzzwords or things to think about with our simple bone cysts, also called unicranial cysts. So our SBC, this is non-painful. We're seeing that the age range is 3 to 14, but you keep it forever. With a simple bone cyst, it starts in our metaphysis, but it can move to our diaphysis. It's typically a little more centric than our aneurysmal bone cyst, and it can have that pseudo-laminated or pseudo-lobulated appearance, meaning it kind of looks like it has a bunch of chambers, but it doesn't have any chambers because, again, it's a simple. It has one chamber. Unicambial means one chamber, whereas aneurysmal bone cysts are multicambial, meaning that it has multiple chambers. So in SBC pseudo, it looks as though it's lobulated, but it's not. And our pathognomonic for a simple bone cyst is our fallen fragment sign. Okay, so now we've talked about 4 out of, right? So now we kind of defined all these non-painful ones. Let's do another image. All right, here we are, and I'm going to say that this thing hurts. This is painful, and we'll say that this individual is painful in a 20-year-old. What is our differential? Okay, so let's get our list out. So painful list. So it's Fegnomashic. So fibrous dysplasia, GCT, osteoblastoma. Our M stands for plasmacytoma, and our blowout Mets, aneurysmal bone cyst, chondroblastoma. Okay, so now I'm going, well, let's do our ages just so that we can keep kind of remembering or reviewing what ages go with what. So starting with our fibrous dysplasia, remember that that is our 8 to 14, but we keep it forever. GCT is 20 to 40. OB is 10 to 20. Plasmacytoma is going to be 40 plus. Blowout Mets is 50 plus. ABC is going to be 5 to 20. And chondroblastoma or Codman's tumor is 10 to 25. So cool, I have my list. Now I go, okay, this is a 20-year-old. So is there anything that I can kind of get rid of based on the age? And really, there's not too much I can get rid of, except I can get rid of my M, right? Because they're not over 50 or 40 or 50. And besides that, I really can't get rid of anything else, right? Because fibrous dysplasia can last forever. So without even looking at the image, so I haven't looked at the image yet, I just was told it's a geographic lytic, painful, 20 years old. I can already cross out 2 of my things. So history is really important. Okay, now from there, we already talked about fibrous dysplasia. Fibrous dysplasia kind of looks like everything. So it's kind of always at the bottom of my list. But the only time it's at the top of my list is if it really looks like a long lesion, a long bone. And does it look like a long lesion, a long bone? No. So it's probably not going to be on my differential. So I'm just going to only 1x, but it's really, I'm not really thinking about it too much right now. Okay, it doesn't trigger me yet. Now I'm going to look, okay, let's actually look at where this thing is. Okay, so we are in, oh, well, that's an apophysis, isn't it? Well, an apophysis should trigger your brain to a ding, 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 immediately go to one of these, right? Our chondroblastoma, apophysis. Chondroblastoma likes apophyses and epiphyses. So apophyses, epiphyses, chondroblastoma. So that's going to be really, really, really high on my list because that's where it likes to go. But I can't necessarily say it's definitely that. So let me look at my other things and be like, okay, well, osteoblastomas, they can be found in the lower extremity if they're going to be found anywhere that's not in the spine, but they're most commonly in the spine. I'm not going to put that really high on my differential list. Usually a DDX has 3 things, so I'm going to kind of narrow this down to 3 things. So now I've kind of narrowed it, right, down to GCT, ABC, and chondroblastoma. So I've already kind of said that I am definitely putting chondroblastoma as the number one on my list. It's an apophysis. There we go. So now how am I going to choose between an ABC and a GCT next on my list? And really, my opinion, it doesn't really matter, but I would put an ABC next. I don't think he would give you any fault for doing it the opposite. But the reason is because GCTs like to start in the metaphysis, yes. So here it would start. But if we look at this, there's nothing happening in the metaphysis here, and it's not going towards the articular surface. And those are the big things with GCT, right? Subarticular starts in the metaphysis. We don't see that here. So even though it could be a GCT, it could possibly be a giant cell tumor, it's not likely. Or it's not as likely as an ABC would be. ABC is eccentric in location, and we see this. It is eccentric in location, and it is a geographic lytic, eccentric. ABC is a good choice, and we're still in that age range where I can say an ABC. So I do CB, ABC, GCT. Now, just like the last one, we've already defined some of the buzzwords for FD, or the main things you should think about with fibrous dysplasia. Let's talk about the main things you should think about when we talk about a giant cell tumor. Okay, so we already talked about age, 20 to 40. And I didn't really say, but the other name for this would be, sorry. I wanted to say AKA. I'll just put the AKA here. Osteoclastoma. So it might be called an osteoclastoma. So, GCT, osteoclastoma, some of the main things that we're going to think about, 20 to 40 years old, it can be quasi-malignant, meaning that 80% of the time it is benign, but 20% of the time it could be a malignancy. You can't tell on a radiograph whether it's malignant or not. It loves to go subarticular. So subarticular starts in the metaphysis. The other thing about GCT is it likes posterior elements. And you're probably like, well, Ree, didn't we talk about a bunch of things that like posterior elements? And I'd be like, yes, you are correct. So our posterior elements differential, which is that alphabet soup differential, if you want to think about that, or I think of it, it's my ago. So my ago differential. So ABCs also like posterior elements. My GCT likes posterior elements. My osteoblastoma likes posterior elements. My osteochondromas like posterior elements, and my osteoid osteomas like them. These three are my geographic lytics. This one is non-painful, and it is the little kind of extensions off of the bone. And osteoid osteoma is where I have that solid periosteal reaction. Pain, child, nocturnal pain relieved by Advil. Okay, so that's my main ideas with my GCT. What about, okay, so we talked about that one. Osteoblastoma. Let's talk about the main ideas about an osteoblastoma. So the main things I want you to think about osteoblastoma is it's a blast. It's a big thing. It's a poof, kind of like it kind of explodes in the area. It is a big osteoid osteoma. You can think of that too. It really loves the spine. We call the center of it a nidus, and the nidus is greater than 2 centimeters. If it's less than 1 centimeter, it is an osteoid osteoma. And it's a giant OO, so that's a big thing with it. We could see a painful scoliosis, but typically a painful scoliosis is associated with osteoid osteoma. So that's the big thing to take away with osteoblastoma. And it also loves posterior elements. So then ABC. let's talk a little bit about an ABC, or the main kind of buzz things that we need to think about when we think about ABCs, or aneurysmal bone cysts. So this is painful, 5 to 20-year-olds. All these are painful, right? And when the kind of big thing is that it looks lobulated sometimes. So because it does, it has multiple chambers, and an ABC, an aneurysmal bone cyst. So it gets its name, aneurysm. So it literally is rupture. So dilation and then rupture of a blood vessel that gets stuck inside the bone. So I'm essentially having this kind of pocket of blood in my bone is what an aneurysmal bone cyst is. So because I have blood in that area, if I were to do an MRI, which you would do an MRI an MRI with contrast in order to assess an aneurysmal bone cyst versus other things, you would find a double density sign. Or sorry, not double density sign. Fluid levels. Double density sign would be seen with an osteoid osteoma, which is the small osteoblastoma. But so I'd see those fluid level lines with an ABC. And that's going to be kind of that telltale thing of like separating or differentiating those. Aneurysmal bone cysts also like the posterior elements. They like to be more eccentric. So they like to be more on the side. And they're they're rapidly expansile. They are not a good sign. Not good. And then our last one, so chondroblastoma. Some main ideas with that one. Also known as Codman's tumor. And it likes the epiphyses and apophyses. And again, also likes epiphyses and apophyses, and it can cross the physis. So we see epiphyses, apophyses, chondroblastoma. Other things that like the epiphysis is an ABC likes the epiphysis, and GCTs like the epiphysis. So these are the three that they're going to kind of always be working around each other. All right. Now that we've kind of defined all the buzzwords for everything, let's look at some more images and look at it. Oh, wham, bam. Okay, so now this one, originally, when you look at it, you should, if I just said, what is the diagnosis? Immediately, I want you to be thinking GCT. That's immediately what I want you to be thinking. Because this is showing that subarticular appearance. So that's like immediately what I want you to be thinking. But if I ask for a differential diagnosis, and we're going to do the Fegnomashic, so we're going to do the long way. Okay, so I was told that this is painful. Okay, I wasn't given an age. We'll just say no age. So painful. Go back. Fibrous dysplasia, GCT, OB. I'm just going to leave the M. I'm just going to do P and BOM. Aneurysmal bone cyst, CB. Let's do our ages. Okay, so 3 to 14, you keep it forever. 20 to 40, 10 to 20, 40 plus, 50 plus, 3 to 20, 5 to 20. The 3 to, I was thinking about simple bone cysts is 3 to 14. So 5 to 20, and then 10 to 25. Okay, so now I have my ages. I know all of these are painful. I was told this is painful. All right. Now, how am I going to kind of differentiate them? Because I don't know age. Okay, well, plasmacytoma is going to look as though it is just like this big expansion. Typically in the center of it is typically where it looks. Blowout mets looks like someone took a cannon and blew out an entire part. This doesn't really look like either of those. So I'm not really thinking those. Osteoblastoma really likes the spine, not so much the upper extremity at all. So now I'm down to GCT, ABC, CB, FD. Now, how am I going to order it? Well, subarticular, I'm going to put GCT first. Then I'm going to be, okay, well, GCT, it is kind of epiphysis apophysis, so now I could go back and forth whichever one I want to put more commonly or more of. I'm going to put ABC next, CB, and then FD would be the last one. Now, the reason I put aneurysmal bone cyst before my chondroblastoma is just in the fact that it kind of looks maybe pseudolobulated. Maybe. But really, these could be interchangeable. But GCT, because subarticular, definitely the first one on my list. All right, now this is not a Fegnomashic question, right? It involves something from Fegnomashic, but what I see here is that ice lesion. So I'm thinking infarct, which we're going to talk about for the last exam. Chondrosarc. And enchondroma. And so based on this, I'm just going to, it would depend on if they said this was painful. So if they said it was painful, I'd put chondrosarc first. And if it was not painful, I'd put enchondroma first. Infarct is also painful, but for now, you don't have to put infarct as an option. You can just put that as your last one. But that's how to go about this. For now, for the final, once we know more about infarct, then you'll be set there. Okay, 50-year-old woman with pain, with ankle pain. I don't know. I didn't write this. So we're just gonna, with ankle pain. Okay, so we have pain. Let's do our thing. GOMAC, FD, GCT, OB, PBOM, ABC, CB. All right, and then we'll do our ages, 3 to 14, keep forever. GCT is 20 to 40, OB is 10 to 20, 40 plus, 50 plus, ABC is 5 to 20, and CB is, brain, 10. 10 to 25. I do it so many times, you know. Okay, so now let's start with just age to narrow stuff down. Okay, 50 years old. Could she have it? Yes, she could have fibrous dysplasia. Could it be a GCT? Could be. Like we have plus or minus, but I'm usually keep that plus or minus within 5 years. So for now, I'm going to exit it. If I can't come up with anything else better, then maybe I'll come back to it. An OB. No. 10, 20, not really. Plasmacytoma. Maybe. Blowout Mets. Maybe. Age-wise, maybe. ABC. No. CB. No. Okay. So now I'm kind of left with this geographic lytic, and I have fibrous dysplasia, plasmacytoma, and blowout Mets. And that's kind of not where I'm stuck at, but that's kind of, these three are common to be DDXs of each other because they all look kind of similar. So now what I'm going to do is just talk about each of them, I want to talk about each of them a little bit. So, because these ones are ones that we haven't necessarily talked too much about. So fibrous dysplasia we talked about, but let's talk about plasmacytoma versus blowout Mets and our main ideas with them. So plasmacytoma is ages 40 plus. Typically, it's a singular form of multiple myeloma, which means they're going to have the lab findings of multiple myeloma. Okay, so remember some of the lab findings for multiple myeloma, because multiple myeloma or plasmacytoma is a B cell tumor. Okay, it is a cancer of the B cells. So we're going to have an increase of B lymphocytes in the blood. We can have a reversal of the AG ratio. So AG stands for, the A is albumin and the G is globin. And globin is found in our immunoglobulins, and B cells are going to be what creates immunoglobulins. So if I have a proliferation or more B cells, I'm going to have more globulins than normal. Typically, so albumin is the protein that is the most common protein found within our body. It's going to have all the amino acids that we really need. It has all 20 essential amino acids. So albumin typically is more, we have more albumin than we do globin. What happens when you have multiple myeloma or plasmacytoma is now I have more globulin than I do of my albumin, and so my G is bigger than my A. So that's one other thing. The thing with this is that 90%, once it goes to multiple myeloma, 90% of the time they die within 3 years. So it's not a really good thing. But also plasmacytoma isn't very common. So it's not as common as some other things. Now let's talk a little bit about blowout mets. So blowout mets is 50 plus. With blowout mets, it's really going to be a singular, so it's very rare that you see metastasis in one spot, but with blowout mets, it's just like one spot, and that's where it is, that geographic lytic appearance. We think about with metastasis, what is my primary? And so we use the acronym RATS to figure out the primary, and that stands for renal cell carcinoma, adrenal, which the adrenal is a placeholder for pheochromocytoma. The T stands for thyroid carcinoma. And the S is a placeholder for skin, but typically the most common is melanoma. Okay, and so that's really all you need to really know with blowout mets. And then we talked about fibrous dysplasia already, long lesion, long bone, all of that. So when I'm looking at this, what would I put, what would my order be? Now for me, I want to know have they had a history of cancer. That's the first thing. So if they have a history of cancer, then blowout mets is going to be higher on my list. With this individual, with their age, and that the pain is just starting. So it's not like, and I don't see, there's no like pathofracture in there. So fibrous dysplasia, yes, it can be painful, but you get it when you're younger. So if it's painful, just randomly starts becoming painful, not as likely. So I would put for this individual blowout first. My follow-up, if I'm ever thinking of that, is I would want them to get a bone scan, plasmacytoma. But I wouldn't order the bone scan. I would send them to PCP. And then fibrous dysplasia. Really, the order that you do here is not, but because they're 50, I'm putting blowout mets first. If this was a 45-year-old, I would put plasmacytoma first, just because of the age thing. All right. Here we have geographic lytic lesion. We see that we have growth plates. So this is a child. So I'm not even going to tell you, right? I'm not going to say it's painful, painless, whatever. I'm just saying this exists in a child. I'm not going to tell you painful, painless. I want you to just figure out what they are. So pause and do it yourself for a second. Now let's do it together. So I'm not telling you painful, painless. I'm just saying, look at this. Give me a DDX. What could it be? What's first on my DDX? Make it a little hard, right? So let's just write out our painful and painless things. So Gomac, and then FENS. So fibrous dysplasia, GCT, OB, PBOM, ABC, CB, FD, and chondroma, NOF, FCD, SBC. Let's do ages. 3 to 14, keep it forever. 20 to 40, 10 to 20, 40 plus, 50 plus. ABC is 5 to 20. CB is going to be 10 to 25. And chondroma is 10 to 30, but you keep it forever. This one is 8 to 20, and this one is 8 to 4, or 8 to 4, 4 to 8. I didn't put fibroxanthoma on this list because I already knew it was a child, so I didn't even put it in the list. And then our simple bone cyst is going to be 3 to 14, but you keep it forever. Okay, so now I know they still have a growth plate. Okay, and so in your head you're like, okay, well, how old can I, based on the growth plate, when do your growth plates close? So typically for girls, they usually close with like 13 to 15 years old, and for boys, it's usually 15 to 17 years old is when growth plates close. Okay, so let's just say that this individual is less than 14 years old. So anything that doesn't kind of fit that idea, we need to X out. So GCT is gone. OB still can be there for now. Plasmacytoma is gone. Blowout Mets is gone. ABC can be there. Chondroblastoma can be there. FD can still be there, right? Both sides. And chondromas can be there. Our NFs, so NOF and FCD, both are good. And simple bone cyst. So now that's really all we've done here. So now let's look at where this is. So if we look here, it is impacting, like let's define the area it's impacting. It is not crossing the physis. So here's the physis. There is my fibular head. So it is not crossing the physis. It's in the metaphyseal region, not crossing a physis. Okay. Well, it's not in the epiphysis then, right? Because it's right here in the metaphysis. Well, chondroblastomas, epiphysis, apophysis, neither of this, epiphysis, apophysis, I'm taking that away. Okay, metaphyseal region, does it look like it has a fibrous matrix? Not really. Does it look like it's a really long thing? Not really. Do I have other options that are better than a fibrous dysplasia? Yes. Taking fibrous dysplasia off my list. Could this be an enchondroma? Totally, but where are enchondromas the most common? Hands and feet. Is this the hands or foot? No. When enchondromas aren't in the hands and feet, it's most commonly an ice lesion. Is this an ice lesion? No. I'm going to take enchondroma off my list. That is not to say that I can't have an enchondroma that's like this, but it's just not as common. Osteoblastoma. Likes the spine. Is this the spine? No. Where else does it like? Well, it does like the lower extremity, but when it is in the lower extremity, it likes to be in the ankle. It likes to be on the distal talus. Is this the talus? No. I'm going to cross OB off my list. So now, do I have 3 things that I could use as my differential? And I do, right? And 3 is that magic number when I'm kind of coming up with a differential. So even though I had no idea, pain or no pain, no idea the age, my differential based on this image, I can go ABC, NOF, or FCD, or SBC. Now I'm thinking about it. Is there bony expansion? Yes. So what am I going to put first on my list? I'm first going to put ABC. The other reason why I'm going to put ABC first is because worst goes first. And aneurysmal bone cysts are way worse than the other 2. So ABC goes first. My next one, SBC. Because you could have expansion with an SBC. Not as much as with an ABC, but you can still have bony expansion. And then my last one would be NOF or FCD. Because I don't know the age, I can't put a single one. But if they're less than 8 years old, then I'm putting FCD. And if they're greater than 8 years old, I'm putting NOF. So there is my DDX. Now let's say that I said, this is where you have to kind of listen to the question. So this is if I said pain or no pain, I didn't say anything. But what if I did say, give me 3 differentials with pain? Let's say that it was painful. And they are 18 years old. Oh no, they're too young for 18. And they are 14-year-old male. 14-year-old male, pain, that's what it looks like. So how would I change this? Okay, well, I would do Gomac. Okay, M is gone because they're 14. GCT, it's kind of gone, right? Because they're 14 and not really common with 14-year-olds. But I'm going to leave it because it's still almost in my 5-year kind of range. So GCT actually, maybe I'll still keep it there. Epiphysis, apophysis, right? It's in the metaphysis. So I'm not really thinking that one so much. Osteoblastoma, definitely not thinking about as much. Fibrous dysplasia, we could still have it on my list. So now I have 4 that it could really be. Now what would my order be? Well, I'm still putting ABC first. Then I actually would put a GCT next, just because it's in the metaphysis and it looks like it's going towards. So as soon as that, what we'd really see is if that physis disappears, like once they go through, once they're fully mature, and then it goes towards the subarticular region, then I'm thinking GCT. Then I'd put chondroblastoma, and then I would put fibrous dysplasia. So you see, like, adding that pain really changes things a little bit, but my primary is still the same one. So what is it most likely? It's most likely probably an ABC. Now, what if I said, let's do it the opposite. What if I said this was actually painless in a 14-year-old male? Okay, well, now I get FENS. So fibrous dysplasia and chondroma, NOF or FCD. Well, I know it's 14 years old, so it's going to be NOF, non-ossifying fibroma, and SBC. All right. So, and chondroma, does it like that location? Not really. Not really. So then here I have my 3. I already have my 3. I don't really have to do too much. So SBC is going to be my first one. Why? Location. Why? Non-ossifying fibromas usually are more eccentric and they're not going to take up the whole thing. If a non-ossifying fibroma takes up the whole thing like it is in this image, the risk of pathofracture is extreme. 50% chance of risk of pathofracture if over 50% is it's occupying. So SBC, NOF, fibrous dysplasia. So just in this one image, I was able to use Fegnomashic to figure out a DDX of 3 things, whether I know if it's painful or not painful, and or whether I have no idea. If I just saw the image, what would I do? All right. Now this one, we are in the epiphysis. So epiphysis, immediately I want you to think, what are the 3 things that really like the epiphyses? And it's a young person. Look, they have growth plates still. Young epiphysis. So young epiphysis is GCT, chondroblastoma, ABC. Another thing that we could have with this individual is a Brody's abscess, but you guys haven't learned about Brody's abscess. The other is we do have a congenital variant right here, right? We have a tripartite, 1, 2, 3, tripartite patella, insignificant other finding. But we do have that right there. But we're looking right here. Okay. Well, it kind of looks like it has caverns. Oh, I forgot. We could also have a fibrous dysplasia, but not likely. So, I'm just going to take that away. We have like caverns. Okay, so I'm seeing all those different little caverns. So my brain, right, is I'm going to put ABC first. Now with this individual, because it's in the epiphysis, I'm going to put CB next, and then I'm going to put GCT. Because again, even though GCT, our age is 20 to 40, it can be 14, 15 years old. Where we still, like we see right here, we still have growth plates, but they're kind of almost closed. So that would be the order I'd put, because ABC kind of lobulated. Chondroblastoma is another good choice, and then GCT. Okay, right here, This is definitely an older individual. Just based on looking at it, we see degeneration, which you're going to learn more about, but I do see degeneration happening. But I know this is an older individual. So older individual, geographic lytic lesion. It's right here. Older geographic lytic. Well, I already know. Older geographic, we have fibrous dysplasia always, plasmacytoma, and blowout mets. So see how, like, yes, I know my Fegnomashic, and if we need to use the longhand Fegnomashic, we can. But in 2 seconds, you can look at an image, figure out age-wise, and kind of break it down too. So use Fegnomashic when you need it, but you're going to get so good after you do a bunch of these that you might just go old person, geographic lytic, my old person, geographic lytic, FD, plasmacytoma, BOM are the main ones. And so for this individual, I would probably, I don't know their age. So if they're between 40 and 50, I would put plasmacytoma first. And if they were over 50, I'd put blowout mets first. And then fibrous dysplasia would be the last one on my list. And those are all of my examples for you. So just going back up to here, what were the main kind of things that we saw is that fibrous dysplasia really mimics everything GCT, along with ABCs and CBs are always usually DDXs of each other, just like plasmacytoma and blowout mets is always a DDX with each other. Enchondromas and simple bone cysts really like the foot. The other thing that you'll think about with the calcaneus is an interosseous lipoma. Besides that, if you guys have questions, please let me know, but this is a great review. Make sure you go back to the more extensive kind of review of all of the different primary malignant bone tumors as well as the benign. And if you have any questions, let me know.